we report the case of a 70-year-old woman with a 66mm arch aneurysm. You see the ascending aorta is non-diseased. You can see here on the greater curvature of the ascending a nice landing zone. Those are the origin of the supraortic trunks to design the endograft. The endograft was designed with 3 branches, 2 antegrade branches for the Innominate and the left common carotid, and a retrograde branch for the left subclavian artery, which has a preloaded catheter, so it can be accessed from the groin. The beginning of the procedure is the fusion registration. You can see here on AP fluoro, we're positioning the red image of the spine from the pre-op CT on top of the spine fluoro image. The same maneuver is performed on a lateral view, and this is performed from table side. It takes a couple of minutes, and then the procedure can be performed switching from the bone mask to the arterial mask. You can see here from the right femoral vein we're advancing a rapid pacing probe into the right ventricle. And the rapid pacing is tested at this stage to make sure that it works properly. From the right groin through the iliac conduit, we're getting a vertebral catheter and a wire all the way up to the descending thoracic aorta, and a Lundaquist wire is positioned in the descending in order to advance a 22 French sheath through the groin into the iliac conduit, and just making sure that the device will track nicely over the Lundaquist wire. Now the wire and catheter are advanced into the ascending aorta, and we are going to position the terumo wire through the aortic valve into the left ventricle. This can be very fast or very time consuming. It's sometimes useful to use an AL1 catheter to get the right angulation to access the left ventricle through the aortic valve. Once we are in the left ventricle, the catheter is advanced and curved at the apex of the left ventricle. Next, a wire is advanced from the right common carotid into the ascending, and then from the left common carotid, a wire and then a pigtail are advanced. The pigtail is positioned against the aortic valve. It's going to be a fixed marker. Now, a Lundaquist wire is advanced through the catheter that was left in the left ventricle. And once the catheter is removed, the delivery system of the endograft is advanced. Always focusing on the tip of the Lundaquist wire into the left ventricle, the endograft delivery system is advanced and not yet positioned through the valve. A first angio is performed in order to check the position of the markers and the position of the origin of the supraortic trunk. And at this stage, we fine-tune from table side the fusion mask. And you can see here, it's an LAO 50-degree position to nicely visualize the coronary arteries as well as the origin of the supraortic trunks. Now the fusion mask is in a nice position. We then advance the delivery system through the valve. a new angio is performed to double check the position of all the markers, making sure that the branches are proximal to the innominate and left common carotid. At this stage, the sheath of the delivery system is retrieved to the first stent. We reposition the endograft in a perfect position. We release the security of the trigger wires, and then we start rapid pacing and unsheath the endograft. There we are, rapid pacing is started, endograft is unsheathed, and the trigger wires are released prior to restoring normal blood flow. And once the trigger wires have been released, we can get the wiring delivery system out of the left ventricle back into the descending thoracic aorta. Now it's time to access the inner branches, and we start by the Innominate trunk branch. You can see here a Bernstein catheter that has been advanced from the right common carotid, 6th French sheath. We're trying to get the wire inside the inner branch, and this requires switching from an LAO position to a RAO position to make sure that we're not pushing the wire in front or at the back of the endograft. You can see here the wire is in a nice position into the branch, so we can advance the catheter. But we need to double check that we're in the branch and not between the graft and the aortic wall. So we're going to push over the wire a rim catheter, and you see once the wire is retrieved and the rim catheter has its shape, we will rotate it at the level of the proximal sealing stent to make sure that we're inside the endograft lumen. And then we're going to go back and try and capture the two distal markers of the inner branch with the rim catheter. You see here we have a conflict between the rim catheter and the two markers, showing that we're inside the inner branch and not again between the endograft and the arterial wall. Next, the Rosen wire is advanced, and we position the gantry to locate the bifurcation of the innominate trunk. You see here the markers of the origin of the supraortic trunk, and also the marker in pink of the bifurcation of the innominate trunk. So the angio is performed from the 6th French catheter in the right common carotid. And with this angio, we fine-tune the fusion mask once again. And then the limb is advanced over the Rosen wire. It's a straight path coming from the right common carotid. Obviously, you have to make sure on one side that you have a full overlap between the inner branch and the limb, and on the other side that you do not cover the origin of the left subclavian artery. The endograft is now released. The delivery system of this limb is short, and so you don't need to cross the valve again to get the innominate limb in position. Now a 12x4 balloon is advanced to mold the overlap between the limb and the inner branch. You can see it inflated now. Before inserting the bridging limb, the right common carotid has been clamped. You can see here a catheter back in the limb, and we're going to shoot a selective angio. There's no flow in the carotid because it's clamped and there's the large sheath inside. So we're happy with this selective angio, and at that stage we get all the endovascular material out of the right carotid, clamp the proximal aspect, suture the arteriotomy, and restore flow. We're now working from the left common carotid. You can see we're changing angulation to check where the wire is advancing and to make sure that it advances towards the inner branch. And now we are in the inner branch, advancing the catheter. We're going to perform again the rim maneuver. The rim catheter is rotated easily here at the level of the proximal ceiling stent, and then going back we will once again see a conflict between the rim and the two distal markers of the inner branch. You can see here now. A Rosen wire is then advanced back into the ascending. The rim catheter is removed, and then fluency stent is positioned with the full overlap. You can see here it's proximal to the two distal markers of the inner branch. We always rely on fluency stent with nitinol stent when the fluency stent is utilized as a bridging stent for the left common carotid. You can see here the nitinol stent is released inside the fluency stent. The next step is to advance an 8x4 angioplasty balloon. It is inflated at the overlap between the fluency and the inner branch. And then move back, and we inflate the origin of the left common carotid. Now a catheter is advanced inside the fluency, and a selective angio will be performed. Again, remember that the carotid is clamped when we do this angio. The left common carotid is closed after being flushed, and the floor is restored. And now we're going to work on the left subclavian branch. So second Landau-Klüver wire is advanced inside the preloaded catheter, and you can see here it's now positioned in the ascending. Keeping this new Landau-Klüver wire in position, the delivery system from the branch endograft is removed and replaced by a short 22 French sheath at the level of the groin. Over the same wire, a 1280 flexor sheath is advanced all the way directly to the left subclavian branch. The valve of this 12 reference sheath is then punctured, and the parallel wire and catheter are advanced directly to the branch. You can see here the tip of the Bernstein catheter, which is rotated towards the left subclavian artery. And then a wire is advanced here inside the left subclavian artery. The Bernstein catheter is advanced. And then a small angio is performed to check that we are in the axillary artery. An Amplatz 260 wire is pushed through this Bernstein catheter. The Bernstein catheter is removed and the Landau-Quest wire, but before, a marked Peter catheter is advanced in order to shoot a selective angio through the 12th French sheath to locate the origin of the vertebral artery and to select the correct bridging stent. Here, a 10 centimeter long Viaban stent was selected and is now advanced over the Amplatz wire. It's released, but still half of the stent is inside the 12th French sheath in order to control the release of the Viaban. And once the first half has been released, the 12th French sheath is removed back and the rest of the stent is opened. Because of the sharp curve to get to the left subclavian artery, we relined the Viaban also with the 19 stent here. The 19 stent is now released. A 12 by 4 balloon is advanced inside the bridging stent and inflated at the origin of the left subclavian artery, and then inside the overlap. When deflating the balloon, we advance the 12th French sheath back into the bridging stent. And the selective angio shows a nice perfusion of the left subclavian artery and a patent left vertebral artery. So access is lost to the branch. We're moving back in order to push a wire into the ascending again. And over this wire, we advance a long Picta catheter to perform the completion angiogram. The two antegrade branches are perfused right away, and then the retrograde branch slightly delayed. But this angio shows a complete exclusion of the aneurysm sac. At the end of the procedure, we performed a cone beam CT, a non-contrast, to check that all bridging stents are nicely open and there's no kink. To make sure that we get a good cone beam CT, we check the rotation of the gantry looking at the fusion mask. You can see here the spin test with the arch always in the middle of the screen. Everyone gets out of the room. And then the cone beam CT is performed. On the AW workstation, we can instantly take a look at CT-like MPR reconstructions. We can check that all branches are nicely open. There's no kink. No conflict between the branches. And also generate 3D VR images to check all that. This is the post-op CT performed a couple of days later, showing a complete exclusion of the aneurysm sac and good patency of the various limbs. The patient stayed 1 day in the ICU and was discharged home 7 days later.